4, 3, 2, 1. We are live now.
Good evening and welcome to this curtain raiser of Assicon 2024. I am Dr. Basu. I am the president of the ASSI, and it's a real pleasure to welcome all the faculty on board. So this SRS worldwide course, which is in conjunction with the Assicon, has been very active and very live for quite a few years. And we have had a galaxy of stars from SRS visiting us and giving us fantastic academic deliberations to make the course a huge success. Keeping in line with the yesteryears, this year also we have a SRS WWC virtual at Assicon. And for the next couple of hours, I assure you that you're going to see and hear the best in the world regarding spinal deformities. I'm extremely grateful to the SRS Board of Directors and Educational Council Chair, Dr. Munish Gupta, who is there as a chair of this session. And before I hand over to him to start the proceedings of the day, I'd like to once again assure you that this is going to be a very interactive program because there are 3 lectures followed by discussions, followed by 2 relevant case discussions. And I think that's all from my side. Dr. Munish Gupta, may please take over.
Good morning. It's a pleasure to be online. I'm sorry I'm not there in person, but I'm sure in the near future that'll happen. But I think this is second best for us, and I'm really happy for SRS and Assicon to work together as we have in the past since 2008. And Basu, special thanks to you and all the faculty. So why don't we start? I think first we have Dr. Laurel Blackmore. She's going to be talking about casting indications, techniques, and pitfalls. Laurel?
Thanks. I appreciate being included in the program. Thank you. Let me share my screen and we'll get started. So is everybody able to see that fine?
Yes.
Okay, so I've been asked to talk about casting. I don't have any relevant disclosures. Just in talking about early onset scoliosis, I think we all understand that the problem is that we're talking about controlling a curve that's getting bigger in a child that's still growing quite a bit. And we know that there's associated early mortality from respiratory failure with early onset scoliosis. And we know that when we treat different etiologies, we have different responses to treatment. So our goals are to maintain normal chest and pulmonary function, maintain the best possible spine function that spine will give us, maintain balance and minimize the deformity, and minimize the risks of deformity of treatment. So obviously we could just use and get it over with, but these children don't do well long-term. This is a old, beautiful picture from Jean Dubasset of a child that started getting surgical treatment at 3 and was already in pulmonary compromise, which was progressive at age 12. So the minimum treatment goals are a thoracic height of 22 centimeters, probably more in more recent studies, and a vital capacity of a minimum of 40%. And casting can be a really important part of doing that because our surgical treatments sometimes lead to the kind of inadvertent shortening that we don't want. So, casting, as you know, I trained on Risser casting, which was just sort of a straight push. And we still actually use a Risser table at Children's National to do derotational casting or meta casting or Cottrell derotational casting, which is a twist and a shift, trying to use the growth of the spine through a derotational corrective force to kind of coax the spine to grow straight. Dr. Mehta repopularized this really with publications in early 2000s. She looked at a large population of infantiles that she was controlling with or correcting with metacasting, and in more than half she saw what was considered full correction of the infantile scoliosis deformity. And then Jim Sanders, I think, reintroduced this in North America for us a few years later with initial presentations about idiopathic infantile curves. And we started to see this trend that they respond best if the children are younger, less than 20 months, less than 60 in his study, and that we could get complete resolution of some of these curves that were at high risk for progression with high RVADs and phase 2 ribs. But some still progressed. Some were controlled and braced for a time, but ultimately went on to surgery. We also used casting as a delaying tactic. This was a study that looked at non-idiopathic populations, and we have now so many larger studies, which suggest that we can delay the onset of surgical treatment for somewhere along the lines of 3 to 4 years on average. So I think that's really the most important thing for us, is that we know that we can't really be starting growing rods and things in 3 and 4 year olds. So this allows us to delay the onset of surgical treatment in children that otherwise are almost certain to go on to early surgical treatment. It's true for congenital curves as well. I think the relative contraindications to casting are very stiff or kyphotic children or insensate children. So Milo children in my population, even with scoliosis, are not good candidates. Children whose chest wall won't allow them to tolerate the pressure of the derotational cast, or children whose pulmonary situation is such that they can't tolerate the compression of the cast. And then the indications are really a moving target, but are any curve that's progressive, really probably into the 20s and 30s, up to people try to control cast into the 80s and 90s in a child that's really either has too small a curve or is too young to attempt to do surgical intervention. So this is one of the kind of tables. I use a Noel frame at one institution and a Risser frame at another. It's important that you're able to apply traction and that the child be suspended for the application. We apply them under general anesthesia and change the cast every 2 to 4 months, aiming for a curve of less than 15 degrees in an idiopathic, if possible, or discontinue casting when we plateau at about 2 casts in a row that aren't getting further correction. I try not to x-ray every cast if it's not clearly going to be time to make a transition. So we're trying to get from x-raying every time to x-raying maybe every 6 months. And then when we hit one of those endpoints, we'll transition to a brace. I use waterproof casting in my practice. This is there's a really good video on the Posna Academy of waterproof casting, which has really helped my practice with tolerance. The patients could take a bath or a shower every couple of days and then rinse, and we show them how to dry it. We apply traction. I apply traction sling right at the apex of the deformity, in addition to the head halter traction and pelvic hip traction. And then I use fiberglass. There's pretty good studies that fiberglass works just as well as plaster, and that shoulder straps don't really add anything. So I don't use shoulder straps because of the extra anesthesia time. Will it work? It works best for idiopathic curves that are relatively small, less than 20-month-old children, and phase run ribs. And this has been seen in several studies. Kids that are stiff on their pre-op traction x-ray, in this study, didn't get success in the sense of curves less than 15 degrees. And although I have sometimes done cast holidays to rest the skin, or because the family just was fatigued from the process, that seems to lower the chances of success. This is just a couple examples. This is an infantile early onset child who presented with a fairly large curve. She was maintained down to a curve, I don't know, we got to 15, I think 20 degrees, and then maintained in a brace. She's now 9.5, still able to maintain with part-time bracing, and has avoided surgical intervention. And this is a child with an undefined genetic syndrome and developmental delay. This is her at 21 months of age. At 3 years, she'd progressed to 60 degrees. We initiated casting. She underwent a series of casts, successfully maintaining the curve for a time, but then came out into a Chenot brace and didn't tolerate Chenot bracing. So she ended up still having surgical intervention, but a delay of about 3 years. Complications include skin problems. I think this is something we've really done better with, but they certainly can still happen. And I'll show you a horrible case of a postoperative child who had a cast problem. We use gel pads. I like the waterproof cast to try to keep the skin in better shape, and really trim it carefully so that you're not having places that are going to rub the child. This is a little girl that I saw was not even 2 years of age with really a dislocation of the thoracic spine. She's treated surgically and put in a cast, and the resident cut the cast to examine the wound when she was called for a fever, and had the complete breakdown, infection of the hardware, loosening of the hardware, bad problems just from pressure in the cast for that period of about 12 hours before it was recognized. So it can go wrong. They can get respiratory complications, mostly not tolerating it. Suken did a great study that showed that the peak inspiratory pressures go up during casting, but then that resolves after windowing. But not all children tolerate the presence of the cast. Repetitive general anesthesia is really the other big concern for us. So in the States, we're still doing anesthesia for casting, although in Japan, Kawakami Noriaki has some good data on casting awake, and it's been tried a little bit in the States, but really we use general anesthesia to try to minimize the amount of time that these children are asleep. I don't add shoulder straps. I try to do some of the trimming as they're waking up and stretch out the casting as much as possible. Other reported complications have mostly been in children with connective tissue disorders. Hypoxemia, hypotension, and cardiac arrest has been seen. There's been a case reported of subclavian vein thrombosis from pressure and SMA syndrome. So I think in summary, this is a really useful tool for us. I'm sorry, I should mention the HRQOL is affected while they're in the cast. It may not completely rebound in all children, so their mental health domains are diminished while casting. This study suggested that they don't necessarily rebound, particularly in idiopathic children. But then another study out of the pediatric spine study group also looked at transitioning to a brace, and once they got into the brace, their scores rebounded. So we hope that that's the case in the majority of patients. But this is really an impact for the families in a lot of ways. It is a really important adjunct for our care, and so we certainly encourage anything we can do to delay the onset of surgical intervention. I think is helpful in our practices. So thank you. Let me stop my share.
Thank you very much. That was very enlightening and some great information. I think our next talk is by Dr. Michael Vitale on use of growing rods, magnetic rods, techniques, and pitfalls. Michael?
Yeah, thank you very much, everyone. And I will just also share my screen. It's a real pleasure to join you this morning for us.
It's right above the draw. It's above the draw icon.
In the middle of the top choices.
Reading view, draw,
Above
and
Zoom.
right above it. Reading view, draw, and right above it.
Go to Zoom.
Orange bar.
Yeah, the issue is can't access that.
Press F5. You can press F5.
Thank you very much for helping me with my technological limits. Well, great talk, Laurel, and I'm going to extend the discussion a little bit to speak about traditional growing rods, magnetically controlled growing rods. I have some disclosures. So we've learned that a number of things in this space, although we're still learning quite a bit. We've learned that early onset scoliosis can be a bad disease given the relationship between the growing spine and lungs. And we've learned and continue to learn to avoid early fusion whenever we can. Laurel's presentation about casting speaks to the power of stalling in any way possible. And I'm going to speak a bit about some of the options. So much has changed over the years, which is great for the kids, because we know that the natural history of early onset scoliosis can be poor. These two landmark studies, often cited Pearson et al., speak to the reality that children who develop scoliosis at an early age can have a decreased life expectancy because of the intimate relationship between the spine, the thorax, and the lungs. And if we do not allow the thorax to grow, then the lungs do not grow either. So we know that this can be a potentially fatal disease for children like this with fused ribs and a disordered spine. Unfortunately, we also know that early fusion can lead to bad pulmonary outcomes. And multiple studies, including a study done at our institution, have shown now that if you fuse a child, if you do an extensive fusion at an early age, outcomes can be quite poor with regard to long-term lung health. which has led us to think about this as a lethal thoracic insufficiency syndrome, as evidenced by this 21-year-old who came into the emergency room many years after a fusion at an early age, which left them with a relatively straight but very small spine, very small thorax, vital capacity of 28%, and she goes on to die of pneumonia at a very young age. So we work hard to avoid fusion. And when I say that, I just want to be clear that I'm not speaking against very limited, isolated fusions, for example, with a congenital hemivertebrae resection. I'm speaking against longer fusions. And despite all the research being done here, we now have more than 12,000 children with early onset scoliosis in our pediatric spine registry. There still remains extensive uncertainty and too many complications. And if I presented this case, which we've done formally in a Delphi group, to the whole panel, there would be multiple options and multiple recommendations as to how to treat this young kid with rapidly progressive early onset scoliosis. So we've sought to approach this by developing better endpoints like the early onset scoliosis questionnaire, a better classification system, and working to sort of better understand who to treat when. This is the classification of early onset scoliosis, which can be guiding. And the most important part is the progression modifier, because I think when we're deciding whether or not and when to treat a child with early onset scoliosis, we generally want to stall and avoid surgical treatment unless that child is rapidly progressive. There are a number of treatment options, and my task is to speak about so-called posterior distraction techniques. And I'll do that. This is the poster child, an 8-year-old, tetralogy of Fallot, rapidly progressive curve. Some years ago, she gets a traditional growing rod, lengthened many times, does reasonably well, and then ends up with a fusion. As so many of these fusions, we often don't get optimum sagittal or three-dimensional control in this child with metal in them for a long time. We've also think about when to use pedicle screws. And if we understand that we want to avoid early fusion, we want to limit the amount of pedicle screw fixation in these kids. And in the situations where we need to intervene surgically in the younger kids, 5 years or less, I tend to like to avoid pedicle screws and prefer rib hooks. And I'll show you some reasons why. This is a case report of a pedicle screw pulling out, causing paralysis. This is another case report of during a lengthening the screw plowing in this young child. So in young children, I will prefer rib fixation. It can be lower profile, although the rib fixation often migrates over time. There's less fusion, more growth, safer. This is what it looks like. There are multiple systems and ways to do this. This is what it looks like in the operating room. We develop a natural plane between the rhomboids and the paraspinals, and you can pull up the rhomboids as a whole, so you get very nice coverage. That's the rhomboid, so-called J-flap. Expose the ribs. This is very easy to do even in sick kids. And we've shown in multiple studies now that if you're going to do this, you need multiple anchors, at least 5 or more, to decrease the chance of loss of fixation. This is excellent for children with myelomeningocele with bad medial skin. In this example, controlling the kid's kyphosis. Here's another example in SMA, and again in spinal muscular atrophy. When these curves are rapidly progressive, I think we can control the parasol and control secondary thoracic insufficiency with more aggressive proximal fixation, as you see here. Here's a child with spinal muscular atrophy with a larger curve, and here we start thinking about hybrid constructs with proximal pedicle screw combined with proximal rib fixation. And here you have a magic magnetically controlled growing rod. We know that complications are common, and this needs to be a part of the conversation with the parents. This is a contract over about 10-year period because there will be blips along this surgical journey. Multiple studies have shown that the complication rate increases over time and probably exists for traditional growing rods, magnetically controlled growing rods, pedicle and rib-based fixation. I'm going to speak a little bit about magnetically controlled growing rods, which have been in our world for about 10 years. These are rods that are inserted and then lengthened in the office using a remote control actuator. The problem with these rods, as you see here, is that the actuator, the part that lengthens, is a straight segment. And I'll talk a little bit about that. These are the lengthenings done in the office, usually at 4 monthly intervals, although our group is conducting a randomized trial trying to understand the optimum lengthening interval. And you can get very nice correction in these children. But again, you see how this creates a forced area where we straighten the thoracic spine because it does not allow kyphosis in that area. I think key to success here is getting adequate proximal kyphosis with bending of the rod above the actuator in the hope of decreasing proximal junctional kyphosis. And this is a child who has multiple successful lengthenings before going on to a fusion construct. Like traditional growing rods, results degrade over time. About 20% of these rods do not continue to lengthen as expected. Rod fracture and implant migration are also very common. And multiple studies have shown now that because of an acknowledgement of limitations in these magnetically controlled growing rods, particularly the issue of failure of lengthening and proximal junctional kyphosis, there was a decrease in the amount of enthusiasm. The yellow line is the use of magnetically controlled growing rods in the pediatric spine study group registry. And you see that although they are still commonly used, traditional growing rods now are used somewhat more often because of some of the reasons that we discussed. So to conclude, early onset scoliosis is still a significant challenge and unsolved problem despite significant technological advancement. We need to be vigilant, prepare for obstacles, have stamina. I think if you are going to be a pediatric spine surgeon, you need to be comfortable with all of these techniques because none are perfect, and there's significant opportunities to do better here. So I'll leave it there and look forward to the breakout sessions together. Thank you, everybody.
Thanks, Mike. That was excellent. And both the traditional as well as the magic rods came out extremely well. I call upon the next speaker, a very close friend of mine, Suken, who is going to navigate through the intricacies of vertebral body tethering in the next 9-10 minutes. Over to you, Suken.
Great. Thank you, Basu. Congratulations on your presidency. And I wish you all a successful Assicon meeting in January in Mumbai. This topic is on VBT. And the reason we're here is that this technology has several promises of a minimally invasive technique for motion preservation and correction of spinal deformity with growth. But there seem to be some unsolved problems and maybe even some mysteries. Depending on how you lie on this technology diffusion curve, you may have already adopted this technology, but perhaps you're waiting for more evidence. I would have to say that the 1- and 2-year results really are attractive. It's a promising technique for exactly what it promises, of avoiding a fusion and some of the problems that creates. And we have seen the rapid adoption of this technique. And in this hype cycle of innovation, I would say that a few years ago, we were approaching the peak of inflated expectations. However, Peter Newton's retrospective report of his consecutive cases really brought us back down to earth, citing only a 50% correction of the curve with a 41% revision rate. Half of the tethers were broken, and up to a quarter of the patients were already scheduled or had a posterior spinal fusion. And when you put your best cases in a paper, this was one of the cases that illustrated the nightmare that might happen with revising a VBT patient to fusion. So actually, the negative press began, and now we were in a trough of delusionment on this technology. And right about a year after Peter Newton's report, we reported at the SRS in 2020, and then subsequently published complications following surgical treatment from fusion over 10 years, showing a rate of reoperation of 6%. 35% of the complications were reported after 2 years, and you continued to have complications even after 5 years. This is for fusion. So the nature of complications presenting early versus late is different, and this became information to counsel families and patients. But the SRS quality outcomes were excellent with regard to patient-reported outcomes. The operation was safe and was a durable alternative. And this then became the gold standard report to which all other innovations should be compared. So when you have this, why would you want to deviate from anything less? Well, we have to proceed with innovation and keep fighting for something that's better. If you look at the enrollment in the Harm Study Group AIS registry, you start to see more and more tether patients being enrolled in recent years, as indicated by the green bars. If you zoom in on those green bars and then divide them up into posterior spinal fusion in blue, anterior spinal fusion in red, which is hardly ever done anymore, and the green tethers, you start to see an increase in that patient population. And when you break down the tethers into single thoracic, single thoracolumbar, and now bilateral tethers, you start to see even dual curves being treated with VBT. What are the current indications? We get this question a lot. In our mind, it has to be a patient with growth remaining. In order for growth modulation to occur, growth has to be remaining. We think the best patients are skeletally immature, perhaps Sanders 3, and the deformity has to be moderate and flexible. And perhaps the best candidates are those who have failed bracing, who are going to approach a fusion anyway. However, indications don't always reflect current practice. In this report by Josh Pays at the Philadelphia Shrine, they showed that there was some lumbar motion loss in spinal fusion patients compared to those who had VBT. Unfortunately, out of the 60 patients, only 15 had lumbar tethers. What this report indicates is that your trunk motion, if you have a selective thoracic fusion, is the same as a VBT, but it's subsequent, you lose 7 degrees per distal lumbar level, so that if you're fused to L4, there's a substantial loss of lumbar motion compared to tether. But overall trunk motion with selective thoracic fusion and tether was no different. So thoracic fusion continues to be the best alternative for most patients in this category. The VBT literature subsequently has exploded. I'll take you through some of the most important practice-changing papers. When Peter Newton compared posterior spinal fusion to VBT in the Harm Study Group, he reported 9 revisions in the VBT group, 6 of which were converted to PSF, no revisions in the PSF group. Half of the patients had evidence of broken tethers. This is the report that indicates that a splaying of the screws of up to 7 degrees may indicate a broken tether. Dan Hornschmeier's series, again, half the tethers were broken with an overall revision rate now a little bit lower than 40%, down to 21%. Again, still 2 converted to posterior spinal fusion and 4 had tether revisions. Rustin illustrated the Canadian experience of Stéphane Parent and Feroz Mianji, showing a 22% complication rate. I think these are where more of the modern papers are coalescing in terms of revision rates subsequently. And this is Feroz Mianji's separating the Vancouver experience, citing a clinical success with the major Cobb angle being 35 degrees or less, was obtained in 3/4 of the patients, and the complication rate was about 28%. So a vast majority of the patients are now avoiding fusion, but still require continued follow-up to see about broken tethers. Amar Samdani's FDA IDE study indicated that 12% of his fusions went on to fusion, 5 for overcorrection, 2 for adding on. We illustrated this report where we measured actual concave versus convex vertebral body growth and disc space changes, and cited that differential growth was observed in the thoracic vertebrae under tether. Differential height changes were also seen in the discs. So the concave side grows faster than the convex side, and there's no difference in overall spinal growth when you're tethered versus normal controls. Amit Alanay shows us that there are mechanical issues and overcorrection in the Sanders 2 group. So they are specifically a group to perhaps avoid tether, citing a higher incidence of overcorrection when you have a younger skeletally immature patient. And Melanie Boyer, along with Dan Hornschmeier, shows that outcomes of vertebral body tethering in the lumbar spine show even a higher rate of tether breakage with single tethers, mostly at the apex. This has now brought on the innovation of using dual tethers in the lumbar spine to avoid breakage. And Baroncini noted that tether breakage in the first 12 months leads to consistently poor outcomes versus tether breakage after 18 months, when you have substantial correction of the deformity and perhaps less growth remaining to ruin the clinical outcome. So I would summarize the current standard of tether as some fail to control progression. There's still a high rate of breakage, up to 50%, maybe all of them eventually break. Overcorrection in the younger group, a significant problem of revision and reoperation. We don't yet have truly accurate predictions of who will respond, as many respond well, but some do not respond at all after correction. We still don't know the 3D effect on spinal growth, with some reports showing good control of the sagittal plane and some no control of the sagittal plane. And we still see consistent rib hump elevation with very poor axial plane control with VBT. The effect of the disc and motion continue to be an elusive goal with only 10-year follow-up currently. We probably need 20 and 30-year follow-up. So there are future unknowns, and complications will likely increase as the follow-up increases as well, just as we saw in the fusion group with more converted to revisions. Is there even surgeon consensus? I think the surgeons that continue to tether will always choose tether. Those that are not tethering will consistently choose fusion. Add this into the mix of social media and marketing of these techniques, and you're in a quagmire of which technique to choose. So back to the hype cycle of innovation, perhaps with implant modifications and collaboration with industry, we are now on the slope of enlightenment as we have more follow-up on these patients, and can conclude that smaller, more flexible curves do best. Intraoperative correction matters. Many of us may have shied away from full correction because we were afraid of overcorrection. We know now that growth modulation in the first year is critically important. Sanders 3 seems to be the sweet spot, with our recent work showing that Sanders 3A has the highest velocity and may be the best time to promote VBT in a patient. Growth modulation occurs at 18 months, and then you get virtually no growth modulation after that. And tether breakage is definitely under-recognized in the current time. So how should this guide your practice? Thoracic curves? Maybe not anymore. Lumbar curves? Let's wait for some more evidence to emerge, but growth is certainly required for modulation of those lumbar vertebra. Double curves? What's the better technique? Double VBT or STF and lumbar VBT, or the hybrid approach? This case may illustrate whether tethering is applicable for both curves, and sometimes this does very well. This is what we consider a bilateral tether, thoracic and lumbar. However, others don't do well, and this may depend on intraoperative correction as well as remaining growth. Are you still deciding between fusion and tether? Well, you may want to consider a hybrid approach, in which you do a thoracic fusion on this patient from T4 to T11, maintain an excellent kyphosis restoration in the sagittal profile, come back in a staged fashion and do a lumbar VBT when they decompensate to the left, such as in this patient. And over time, this seems to be a really attractive approach, preserving lumbar motion and still restoring a good axial and sagittal plane in the thoracic spine. So if you ask yourself whether you should be doing this, there are some people who are not going to do it. And there are some patients, there are some surgeons who are doing it all the time. I would urge you to be vulnerable, be honest, ask the right questions, and follow the evidence. Thanks very much.
Thank you very much, Suken. That was quite honest and enlightening. I think that now we have some time for discussion.
Okay, can I start it off, Basu?
Yes, please.
Yeah, Suken, great talk as usual. Thank you.
Thanks.
What do you feel about the flexibility of the curve and the amount of intraoperative correction that you get in these patients with VBT? I mean, is that a big factor between, how do you decide? Does that make a factor in your decision?
Yeah, I mean, there are two ways, obviously, of deciding about flexibility. You can get X-rays, either bending X-rays or stretch X-rays, and I think that the clinical examination is also very important. But intraoperatively, we seem to get better correction over the bending films because under anesthesia and muscle paralysis, we can do some positioning which can help us correct the thoracic or lumbar curve. I think our group, as well as Laurel and Michael, do not prefer incising the disc to gain flexibility because we think that actually goes against one of the mantras of trying to preserve motion and disc health in this operation. So that doesn't correlate well with us. So I think intraoperative correction is key. And what we've found is that if you don't get enough correction, the modulation of spinal growth doesn't seem to happen very well. The tether is loaded abnormally, breaks on the earlier side, and you get deformity recurrence requiring some sort of revision, whether it's another tether or whether it's revision to fusion. So to answer your question, I think intraoperative correction is critically important. And as long as this patient is not Sanders 2, more in the Sanders 3 category, I would go for full correction intraoperatively. When the patient stands up, you tend to lose about 10 degrees of correction. And as long as the tether is intact, you can gain some further correction over time.
And if I can just add, what percentage in your cases the correction was intraoperative, and what percentage of correction occurs after in the follow-up period?
In the flexible curves, most of the correction is obtained intraoperatively, and depending on how much growth modulation you have, you get further correction over time. So I would say that the best cases in which you get a beautiful looking X-ray in longer term follow-up was 50-50, correction intraoperatively with further growth modulation over time.
Thanks,
So-
Suken. I've asked a question to Laura. So what is your earliest age group where you would be happy to go on for casting, and what would be the oldest kid that you would like to cast?
So I will start casting in children that are, 18 to 24 months. I mean, I worry a lot about the repetitive anesthesia in the very young children. I think the oldest it depends on the size of the child. I've casted 8 or 9-year-old children tolerated. I think you'd be hard pressed to convince a 9-year-old idiopathic case to get into a cast in our, I think in North America, they just are resistant to that as they get older, but and the curves are a little stiffer. So we worry a little more about, but I think any curve that's flexible in the child that'll tolerate it, that you're trying to delay, either, get a cure or delay, is reasonable. We are moving more towards, and investigating more now that I feel like we have better bracing techniques. We use more derotational bracing, like Chanot style braces, that when can we forego casting, or when can we transition earlier to bracing as an alternative to repetitive casting. So that work we're looking at that in the pediatric spine study group right now, sort of trying to see how often we can brace instead of casting, or how quickly we can transition to bracing.
And have you ever used that cast once you remove that cast in the final stages before you convert to bracing? Have you ever used that cast mold as a negative frame in which you can mold your cast on? Mold your brace on. Have you taken that mold
haven't.
for bracing?
No, I've had the orthotist come into the operating room and mold the last brace so that it's ready as soon as the kid's finished with casting. But I'm fortunate to work with an orthotist that we can usually get the braces within 10 to 14 days of being able to measure them. So if they did measure them in the operating room, which again, if it takes too long, that starts to make me unhappy. So we usually get them measured as soon as they come out and can get the brace on within 10 to 14 days.
So, Basu, we're getting some questions on the chat. Suken, can you talk about the difference between thoracoscopic BVT versus open BVT?
Sure. I think that most of us would use the thoracoscopic technique because if you're trying to fulfill the promises of minimal pulmonary dysfunction, minimal pain, faster recovery, motion preservation, you'd like to avoid doing an open thoracotomy. And so this technique has lent itself to thoracoscopic surgery quite well. And you can pretty much do every level between T4 to T12 without any trouble. Then you can go across the diaphragm down to L1. Where it becomes troublesome is trying to get higher than T4, and the vertebral bodies are very small. But then you're looking at a double thoracotomy, which we don't think is going to be of much benefit. So I would say that from a pulmonary function standpoint, you want to stick with the thoracoscopic technique, unless you don't have experience in that. And then going with an open technique is fine. just knowing that it's going to be a little bit more dysfunctional with pulmonary function. And then there's a question about posterior VBT. I would say that the closest device is a posterior distraction device, which is currently under study in the US as part of an FDA trial. It looks like the early results are pretty good, but this seems to be more applicable for smaller curves rather than some of the larger curves, which might be addressed better by fusion.
We'll have Dr. Sujit Srivastav's question, and there is a question for Laura regarding casting in thoracic curve before we go on to the case presentation. Dr. Srivastav.
Yeah. So actually, this non-fusion technique in curves which are extending into the cervical spine, it is actually difficult for casting as well as the other modalities. What is the comment of experts on this? When the scoliotic curve, it is extending into the cervical spine, I would say cervicothoracic junction, how to tackle that?
Yeah, it is difficult. I can't, we can't cast, I can't get any control with an apex really above about T7 or 6. So nerve tight cast for anything like that. So I think then you're looking at trying to do a very limited fusion if it's really putting the head out of balance, but we'll tolerate a fairly aggressive upper thoracic curve, and understanding that we really can't treat that unless you're going to treat it with surgical intervention.
Suken, I want to ask a question because it's on my mind. You mentioned the thoracic spine and fusion there, but the lumbar spine, where you want to preserve motion, you're putting double tethers to kind of make sure they don't break, or if they break, it's less. But if you have a double tether and need to revise, have you had to revise some of those patients? And is it hard to put pedicle screws since you're putting more screws in the bodies?
I think the revision to another tether is very difficult in the retroperitoneal space because of the scarring issue. So I think most people would approach the revision work posteriorly. And I think about that when we're putting in vertebral body screws. I want to go at the mid third to the lower third, especially with double screws, to avoid blocking entry from posterior to anterior. So personally, I think about that. Sometimes the vertebral bodies are small and you don't have the luxury of placing multiple screws. So there might be some technology in which you have a single screw that allows holding two tethers and other innovations like that. But for the revisions we've done for the thoracic tethers, motion is preserved. You get a reasonable correction. You're able to derotate and get nearly the same results, I would say, that you would from a virgin case, except you tend to have to go a level or two longer than the initial tether was applied just to get the same control of the deformity if they had a fusion in the first place.
Michael, I have a question for you. You mentioned that the tendency is going away from some of the magic rods and doing more traditional growing rods. Can you sort of give us an idea of which patients you prefer to have the traditional growing rods versus the magic rods?
Yeah, I think as Suken showed, at the outset of magic, there was a lot of enthusiasm. And then once we started to understand that many of the complications were the same, and there was the additional complication of decreased lengthening and eventually failure of lengthening over time, people started to back away from it. There was a phase where there was some issues with the implant. There was a recall, and that's been fixed now. But I think people now are looking at children who are very kyphotic as not being ideal candidates for a magic because of the straight actuator. Larger children, stiffer curves. Those are, to me, the relative contraindications. The fourth one is children who are very anxious, because it can sometimes be difficult in the office to get the kid relaxed enough lying down to allow us to do the lengthening in a way that's dependable. And for some children, going to the operating room twice a year might be a better option than driving to the office and waiting for us and having a lengthening. So I think there's a mix over here, but it's stiff curves, kyphosis, anxiety. Those are the main things.
Munish, can I ask a question real quick?
Yes, of course.
Michael, let's talk about it another way. Are there diagnoses or pathologies where you would say magic does perform well and you would consistently use it?
Yeah, thanks, Suken. I think that the sicker or more involved medically the child is, the less we want to take that kid to the operating room and cut them open and risk infection. So I love magic for my spinal muscular atrophy kids, for example. I think that the kids who are very flexible in this connective tissue disease kids do really well. And on the flip side, with magic, on the flip side, the kids who are more rigid, like the arthrogryposis kids, do not. So those are some of the things I think about it. What about you and Laurel?
Yeah, I would agree exactly with you.
Yeah, big stiff curves. I've been going back to traditional growing rods.
Michael, I have one more question. You mentioned the parasol effect, and I think that's one of the big challenges in my practice. I can get the spine straight and maintain that, but I cannot do anything for the parasol effect. You have any ideas? All three of you.
Yeah, we're very close to being able to show this with data with good outcome, but I think you can. I think that rib fixation, some of the constructs that we showed really can be effective at keeping the umbrella open. So in any SMA kid, I am using rib fixation, even if I'm using pedicle screws right now as part of the hybrid construct. I think that it's really important, as we know and have seen in the studied, traditional growing rods did not keep the parasol open. So I think those kids need a higher density of proximal implants, which include rib fixation. And again, we're very close to being able to show this. So I would just ask that any kid that you're operating on with SMA consider proximal rib fixation.
Thanks, Munish. I think we need to go over to the cases.
Yes, agreed completely. So
Yes.
our first case discussion presentation will be Dr. Kandwal.
Hi, good morning, faculties from America, and good evening to people from Indian subcontinent. Without much ado, I'll share my screen here. Thanks, Dr. Basu, for giving me this opportunity. And I have this case of a 13-year-old girl. Is my screen visible?
Yes.
Okay. So we have this 13-year-old school-going girl who came to us with deformity over lower back for last 1 year, and she also has occasional back pain. She's 1 year post-menarche, and on examination, her head is central. The shoulders are at same level. The spine, there appears there was a left-sided lumbar curve, and there is asymmetry of lumbar crease. You look at the patient clinically, that's how she looks. And you can appreciate that she has there's not much of coronal or sagittal imbalance clinically, and she has multiple caphylase macules on her back and entire body. Quick look at the morphometry, everything looked fine. Upper segment, lower segment ratio was fine. Arm span was good. Looking at the diagnostic criteria, we thought it was most probably neurofibromatosis, and she was fitting in. Her mother was having neurofibromatosis, similar kind of illness, and she was meeting the criteria, and we thought it was a case of neurofibromatosis with a lumbar curve. On clinical examination, further neurological examination was normal. There was not much significant finding on the neurological examination. Jerks were symmetrical bilaterally, and now we have this case of suspected neurofibromatosis, and we also kept idiopathic as one of the differentials. Should I stop here, or should I go ahead with the imaging?
You might want to put the x-rays up again and then ask the panel.
So these are the x-rays, and if you look at the measurements, okay, I can't share it now. Okay. Slide is not moving.
So since he has these x-rays up, obviously the diagnosis, I think with the cafe au lait spots, you can pretty much assume it's neurofibromatosis, and also the vertebral bodies look dysplastic. You guys want to comment? Laura, why don't we start there and then we'll go forward.
These are the measurements.
Thanks. Yeah, I mean, these are it always makes you sad when you see a curve that's going down that low, and I can't quite see the looks like the LEV is L4. As you know, with NF, I find it helpful usually to get some advanced imaging, because the anatomy of the pedicles, if you're considering fixation, can be really challenging. I don't know that we have any experience with growth modulation, and I do not in NF. To me, this would probably not be a good person to consider growth modulation, so I'd be considering instrumented fusion for her.
Michael, Suken, comments?
I agree with Laurel. We did study syndromic indications for VBT, and the outcomes were generally not very good. So even in the flexible Marfan's type kids, the amount of add-on made it such that it's probably not a great indication. This would be a fusion. I agree with advanced imaging. This is a case that more and more I'm using navigation. Be prepared for CSF. CSF can be anywhere in these kids. And you cannot go short. So, L4 is the end vertebra, but, I think there's a question about how proximally to go here as well. You really can't be too selective with these children. So I agree with Laurel.
Suken, what are the things that you watch out for in these cases? Because there's many.
Well, the MRI is going to help you with dural ectasia, which I'm thinking with a dystrophic curve like this, you're going to see very frequently. Very thin pedicles. I mean, the pedicles at L1, even in a normal South Asian kid, are going to be small. So I would expect that's going to be the hardest vertebral body, or perhaps even the apical one at L2 being the hardest to instrument posteriorly. And I think that, everyone gravitates towards thinking about a posterior approach, but I've done a few of these lumbar curves in NF anteriorly, because I would tell you that Al Crawford still advocates in dystrophic NF to go anterior posterior to get the best long-term result. And in several of these patients, I went anteriorly, instrumented, got a great correction, and was going to stage them posteriorly, but didn't need to. So, I don't think we should discount the anterior procedure with instrumented fusion for a patient like this, which may ultimately save a motion segment, perhaps. But I think we need to assess the flexibility. We need an MRI and do what's best in your hands to preserve the sagittal plane. I don't think anyone wants to do anything in the thoracic spine on this patient, so it would be a relatively short fusion.
But Suken, isn't the same true for a posterior approach? I agree this can be done anteriorly, but I don't think I've seen in modern day high density pedicle screw surgery a non-union from the back in a case like this. So I think less and less are we thinking about this disease as one that requires circumferential fusion. Would you agree with that?
Yeah, I would. I just want to present a different viewpoint. Yeah, I think the dural ectasia is. I would hope we wouldn't be considering tethering, but there have been a few isolated cases of screw impingement erosion on the dura, and if with dural ectasia, I would either any kind of fixation, anterior or posterior, you're going to have to worry about that. But there's just less body to work with to put an anterior screw into.
So I'm sure Pankaj has something up his sleeve. We can show the rest of it, Pankaj.
Yeah. So I'll go ahead with what was just discussed. We have these. I'm just not able to go forward. Okay, one second. Okay. So yeah, so she was falling in the category of a dystrophic curve, as we just discussed. These are the bending films. You can see it was the 62-degree curve was bending to 32. And we do get a fulcrum bending also in selected few cases. Do you want me to go ahead, or you want to have a discussion on this?
I think you can go ahead and show us MRIs whether there's a dural ectasia or not.
So these are the MRIs. I put in the T2 sagittal images here, and you can see there's a lot of scalloping, and I can go ahead with the axial cuts. These are cervical spine. Yeah, so these are the lumbar curves, the lumbar MR.
So is there a paraspinal neurofibroma?
I don't think there's a neurofibroma here,
I think there
Yeah,
is a
that's something to
plexiform
look
stuff
for.
there.
but
It's
there
something to look
is
for.
dural ectasia.
Yeah, it's something to look for because that can cause significant bleeding if you get into the neurofibroma.
Okay. Not that I can see on the convex side. Okay. So, any further investigations or should I proceed?
I would always be keen to go ahead with the CT to understand the pedicle anatomy and the feasibility of putting in screws, especially at those apical concave dysplastic pedicles.
So,
So here
Basu,
we go.
it's always going to look small. So does that, when you get a CT like this, what do you do with that information? I mean, this is not unexpected, right?
So here we have the CT scan. The convex pedicles are appearing very narrow and they're like slit-like. There's no cancellous channel at all. In most of the pedicles, especially around the apex, you can see there's not much of cancellous bone.
You know, I think these pedicles look much better than it could be. So
Yeah, I agree. I
Me
think the
too.
dural here is moderate, not severe.
yeah.
I thought when you're showing the CT scan, you're going to show sometimes there are absent pedicles, just a thin wafer pedicle is there.
Now you look at the L2 and L3, they're really narrow and slit-like kind of pedicle, cortical kind of a pedicle. So if there's not much to discuss, then I proceed.
Yeah.
Okay.
Go ahead.
So I thought I'll go. Yeah, this is the Lenke-Varnabe classification of pedicles, and this was somewhere falling in cortical channels, or at the apex it was like absent pedicle channels. And I preferred going anterior in this patient. This is how I went ahead, and I just followed the principles of anterior surgery, and did gob to gob, and that's how the pedicle screws went in. As you could see, there was a lot of dural ectasia. I was slightly worried about putting 2 screws in each body, and that's when I took a decision of just going 1 vertebra, 1 screw, and then this was followed by good discectomies and interbody fusion with help of cages. That's how the X-ray looks in the post-op. Any comments or how
it looks really good. So if these are standing X-rays, I think the sagittal plane looks nice. Sometimes with anterior surgery, you can kyphose the patient, but I think with the structural grafts, you did great with that. And I do have to say that you can follow this patient if there's some loss of correction. It looks like you still have the opportunity to instrument posteriorly to supplement, but I'm not sure you're going to need to. If you have follow-up on this patient, I would love to see, 2 and 5 year follow-up showing good fusion. And did you use rib graft?
Yes, I morcelized the rib graft and put that in the cage before I
looks really good. Looks really good.
So and I fused all the vertebra from D12 to L4, and we kind of saved 2 motion segments distal to it. So this patient was in follow-up, and she came. This how this is one of the advantage of anterior surgeries, and I being I'm a big fan of anterior surgeries, and you can see how derotation happens with the anterior surgery. And this patient came to me in follow-up now, and that's how she looks now. Sagittally, she's well maintained, and coronally also she looks fine so far. It's like 1 year follow-up now, and I'm just keeping a close watch. As Dr. Suken Shah said, I had an hunch that I might go posterior and just do a fascial fusion and do a short fusion posteriorly. But so far she's been doing fine. I'm keeping her closely in follow-up. That's her clinical pictures, and that's how she looks.
That's great.
That's a great result. But as you know, these neurofibromatosis need close follow-up. Even if you have a solid fusion, years later, this doesn't look as bad, but some of them, they eat up the bone and then you're stuck doing other things. But that's a great case. Any other comments by the panel?
Great.
All right, shall we move on?
Please stop sharing.
Yeah, thank you, sir. Thank you for giving me this opportunity. I'll stop sharing.
Thanks, Pankaj. Great case.
Case.
I think next Naresh is all set to go ahead with his case. Naresh, you can share your screen.
Thank you, sir. Are my slides up?
Yes.
Thank you. At the outset, thanks for the opportunity. And I thought this is a galaxy of the best in the world here. Want to show one of the difficult cases which I've faced in my practice. We quite rarely see these kind of severe deformities and where we have issues with fixation points and how to deal about this one. This patient is a 12-year-old male patient with osteogenesis imperfecta diagnosed before. And he presented with the progressive deformity of the spine. And there was a history of frequent fractures, but the neurology was normal. These are the plain films in the anterior and AP view and lateral view. So that's the clinical presentation of the kit. You can see the significant thoracolumbar hump over here and elongated pedicles. I have never seen this long pedicles in my practice, and I'm faced with this kind of scenario. And you can appreciate the bowing of the legs and clavicles deformed. There are the previous fractures which are malunited. And this is the presentation now. So I leave it to the discussion how to go about it. Basu sir, can you take over and then start discussing about it?
Naresh, can you show the images also of the CT and MRI that you have done, because they will be very critical to know.
These are the other images which we have faced. This is the, you can see the previous fractures which are healed and the cervical spine, just to rule out the craniovertebral anomalies or not. Then the other skeletal screening was done in the patient to make sure that there are no other pathology. These are the sagittal CT scans. Significant increased lordosis, quite elongated pedicles on both sides, almost the horizontal sacrum. So 3D reformation images of the same patient. In the MRI shows wide canal over there and the quite significant distance from the posterior lamina to the vertebral body. The traction films in the anterior, posterior, and lateral view. No much of deformity correction at the lumbar junction, but the adjacent segments are getting corrected quite a bit. This is how the kid walks. The posterior hump. Yeah. So I leave it here now.
That was a great presentation and a very complex case, very impressive deformity. Why don't we start with the panel, see what they have to say, and then if anybody else wants to comment, we have great experts on this video. So go ahead, panel. Laurel, you want to start, and then Michael, and then Suken, and then maybe Raja has some comments as well.
Yeah, super impressive deformity, and these are obviously really challenging. I haven't had, I love traction for severe kyphosis traction in the lumbar spine. I haven't had much. I can't say I really have been impressed with, although I think traction in general in these deformities can be helpful. I don't know about something this low. I think you're going to have to do a pretty extensive fusion, which makes you sad in a 12-year-old. Because you're going to have to get up into the thoracic spines and frank lordosis. And I think you're going to need to do, some osteotomy work at the apex of this deformity. Suken, I know, has a lot of experience with OI with fixation techniques, so I'll defer to him about sort of some of his tips and tricks to try to get adequate fixation in these kids. But to restore the sagittal plane, you're going to have it's going to be quite a lot of work, and it's going to be really centered in that lumbar kyphosis.
Yeah, I would agree with that. First of all, I think without understanding what type of OI this kid has, I think we need to get flex X views and make sure his cervical spine is stabilized. Has the child been optimized medically with regard to bisphosphonate therapy? I'd also be sort of thinking about that. And then with regard to surgical treatment, it's sort of interesting. The kid has two sagittal apices, one that's a little higher at maybe that's 3-4 in kyphosis, and then a lower apex at 4-5-1 in frank lordosis. So, I'd like to see X-rays over a bolster, but the MRI did not show a lot of flexibility at that upper apex. The thing I am thinking about is what my N level is here, because to deal with that more distal hyperlordotic deformity, I think we would need to go to the pelvis. I would try to avoid that maybe with aggressive osteotomies through that upper apex. Likely only posterior column osteotomies, although a larger osteotomy is potentially necessary. And yeah, I think, depending on the quality of the bone, we may need to go longer to get better fixation. May need to use cement augmentation techniques.
So, Michael, what do you think will be the best form of fixation? Because these pedicles are they are so long, elongated, and very thin. And if you look at probably L3, they're all these wavy pedicles. I mean, they don't have a trajectory where you can start with from the posterior side. And these pedicles the trajectory doesn't end into the vertebral body. So what will be your fixation?
I think using navigation, we can get posterior pedicle fixation, even if it's largely body fixation, vertebral body screws. The question is, in his weak bone, if it's going to be adequate to allow correction and durable control, or whether or not we're going to need to go to the pelvis. Going to the pelvis ultimately will give us much better fixation, with the obvious downside as well.
Suken?
I think Bhabuk has some experience before Suken comes in.
Oh, okay. Bhabuk?
Yeah, obviously, sir, it's a difficult case and it requires, the complex planning. Maybe we can plan, some sort of front and back VCR. We can just take it out this L4 vertebra from the front, and then we can take out these pedicles from the back, and then I think we will need to go to the pelvis here, and from here at the above this thing, we can just get away with the posterior column osteotomies proximally. And obviously, we have to use the navigation here.
What would be levels of fusion?
So I will have to go to the pelvis here, and proximally I will go to the lower thorax, maybe by T8 or T9.
The hyperlordosis in the lower lumbar spine would be a very major difficult technicality in putting in screws deep down with the pelvis and L5 and S1 possibly. Suken, yes. Your views.
Yeah, I question the diagnosis because it seems he's either really a mildly affected OI with something else, such as Bruck syndrome. He has no fractures, no bony deformity, but his small stature makes me think that in addition to OI, there's something else going on. So he needs a full genetic workup. And then I think in the chat, someone mentioned bone mineral density. I think that's helpful because you might make the assumption that he has OI, but some patients with type 1 actually have bone density that's reasonable. And if not, then I would optimize, as Michael suggested, with bisphosphonate therapy prior to approaching this surgically. If you look at his regional alignment, he's got pelvic retroversion. So he acts like a high-grade spondylolisthesis. Many of these patients have a higher PI and very significant lumbar lordosis, and he has the kyphosis in the mid-lumbar spine, which is all sagittal plane. There's not much coronal plane stuff going on. And his thoracic lordosis is compensatory for the lumbar kyphosis. So when you look at him globally, he's got a positive SVA, but his pelvis is retroverted. I don't think a VCR is the best approach, but I think a PSO at the apex of the deformity with several posterior columns above and below to try to titrate the correction. And I agree with several of you who thought that the pelvis is the best lower anchor. But beware of instrumenting the pelvis in OI. It's not as straightforward as you might think, especially in the severe types. It becomes wafer thin and it's actually quite wavy. So putting a straight screw into the pelvis is rather difficult. For those of you of that navigation, I think this is where navigation really shines, because the anatomic pathways we know we can do freehand with screw fixation aren't going to apply here, both in the sagittal trajectory as well as the axial trajectory. And obviously the pedicles are going to be quite thin. So I would say I want a genetic workup. I want to optimize with bisphosphonates, and I would go to the pelvis, augment with cement where necessary, and stop, if I can, at T10, but leave open the possibility of needing to stage to go higher in the thoracic spine if some of that lordosis doesn't resolve on its own.
Anybody else have a comment? Raja, would you like to comment?
I think Naresh can show us what he did, because we're already 10 minutes late.
Oh, okay, okay.
Thank you for all the inputs. I think the same thought process has been going on when I faced this issue. So patient was already on bisphosphonates. He has been treated for that because he had a previous tibial fracture. The treatment was started then. As Suken rightly pointed out, the diagnosis was probably considered as a OI, but not confirmed. But Raja sir has rightly pointed out, we have a navigation which is CT based. It's not like introp spin. So we try to put the screw, but never was able to find the trajectory. Even the pedicle was able to show the trajectory of the pedicles, but the entry and the vertebral body were not falling in line. Whichever way you try, either it's going into the pedicle of one, L3 was actually leading to body of L4. So that was a little tricky for us to actually try to put the screw. As Bob pointed out, we initially thought of doing as a wedge resection or PCR, but unless I get a strong point, fixation points, I didn't want to go into the vertebral body, because I'm not sure whether I am able to stabilize the spine without getting a strong hold on the spine. So what we have done, like we have gone to the pelvis and fixed the spine. Like Suken said, we stopped at 90-10 level. That's what we could achieve by doing fixation. So coming to the closer look at the way the screws have gone in, we were able to put screws in one of the typical deformities. The body was able to reach up to the pedicle, and the length of the screw were not quite good. Up to 50, you were able to not reach the vertebral body. So any comments on how to follow up this patient for the future? What could have been done better in the patient?
Naresh, I think it looks really good. What did you ultimately do in terms of osteotomy? Did you just do posterior column, or did you do a PSO? Because I see the wafer. I didn't know if you did an eggshell or something.
No, it is just the manual correction, and we did some decompression and then gone into everything fall into place once we put the screws and corrected it. Not much of vertebral body resections was done.
I think it looks good. I would just keep an eye on the top level. Just make sure you don't get plowing and pull out. But so far, the SVA looks pretty good. How much follow-up do you have? I see the staples still in.
No, that was the previous one. I think this patient now we have follow-up of 9 months. 9 months, still holding on. I think we have watching video. Let's see.
Thanks, Naresh. That was really good. And as Suken rightly mentioned, we'd really be looking forward to see long-term follow-up of this kid. Need to be very aware of the top screws, whether they're coming out or whether PJK develops some. You have any slides more to show?
Is there a role for an anterior fusion now?
So, Ken, do you feel an anterior fusion would add to the stability of the construct?
Yes, I mean, it would. But which levels, Raja, are you really interested in? Because he's got fixation above the diaphragm and below the diaphragm. Are you thinking about augmenting the lumbar, or are you thinking about doing some lateral inner body in the lower thoracic spine where you want to strengthen the construct?
I was mainly thinking of the lumbar one.
Okay. Okay. Yeah, I mean, anterior column support always helps. Whether it's going to be necessary, I honestly don't know.
I would agree with that. I think this looks really good. You have good restoration of sagittal plane, although it is interesting to note that his cervical kyphosis has increased even in the short term here. And I think I would hold off on doing anything anterior. You have great fixation, you know, at most of these levels. But the other reason I would hold off is because the story may not be over with regard to what needs to be done posteriorly if there's PJK here. So I think it looks great in the short term, and I'd just sit on it for a while.
I have a comment. It looks like, I mean, he's standing in this picture. The pelvis looks even more retroverted to me. Maybe he's trying to really stand up straight. That's one of the things you have to watch out for. And I think the anterior fusion will be a good thing if you feel that he's loosening anywhere in the lumbar spine, just to solidify the most stressed area would be the low lumbar spine.
Okay. Thanks, Naresh. I think that was an excellent case, and Munish would start off with his next talk. We'll go into the next session. I think Kshitij is ready with the presentation of Munish, and this is a very important topic on PSO, and it's lovely to have Munish, who's one of the experts in PSO, to present this, because I have heard this talk at least quite a few times, and I've always got more technical details than I expected.
This is Munish Gupta. I'm going to give you a talk on pedicle subtraction osteotomies, indications, techniques, and pitfalls. And I'm sorry I'm not there in person, but I hope to see you guys soon. These are my disclosures. Sagittal plane deformities are probably the primary use of using pedicle subtraction osteotomies, but they can also be used with minimal coronal plane deformity, especially with people who had multiple surgeries. Sometimes that's the only choice, is do a pedicle subtraction osteotomy from the back. This is basically what happens. You take the posterior elements, you take the pedicle, and then you create the lordosis, typically in the lumbar spine. And this was a cartoon that I borrowed from Schwab and Lafarge. A little word about technique. I think positioning is important, decompression is important, the osteotomy itself, how you do it, and then the closure. So most important part in positioning is using a table that can bend to help in correction. Make sure the abdomen is free so you don't get back bleeding from the venous structures, and make sure you pad all the pressure points. I started doing it on this table, but now I like to use this table that is easy to place the patients on and correct the osteotomy. The decompression is probably one of the most critical part. You do a midline laminectomy, extending above and below, and then also making sure that you follow the nerve roots out from both sides. You want 6 pedicles and 4 nerve roots. This is a cartoon showing the posterior elements. This is the kind of decompression you need, with 6 pedicles that can be felt, and then 4 nerve roots that are isolated. This is a clinical picture of 4 nerve roots you can see, and you can see the semilunar decompression above and below. Then you dissect outside the body, you hollow out the body with curettes, you take a ronjo to the lateral body wall, and then you use the table to correct to close the osteotomy using temporary rods to control the correction. Just to show you in diagrams, this is when the body's all hollowed out. This is what it looks like in a sawbone model. And then this is a clinical picture of how the body's hollowed out. You can see the pedicle wall still protecting the neural elements. And then you take the pedicle, You can use osteotomes, which I typically do to remove some of the bone. And then the last part is to collapse the posterior wall into the cavity you've created. Once you've completed the bony resection, you can then use the table to close the osteotomy with temporary rods. There's an example of the closure. Now it's open and now it's closed. And then you tighten these small rods, and then you could put your longer rods. Just to give you some examples, this is a 67-year-old female with multiple surgeries. You can see coronally and sagittally malaligned. And after the PSO, you can see the small rods and the long rods, and you can see the correction clinically in coronal and sagittal plane. This is a little bit of a worst case scenario where they have not only a flat back, but also a fracture of L4 body. And you can see that close up with the L4 is like a triangle. This is opening up in the back, decompression, isolation of the body with some ribbon retractors, and then finally the closure, and then the longitudinal rods independent of the small satellite rods. And this is what it looks like close up. We also put structural graft in the disc spaces above and below L4 and L5. And this is the correction. You can see the restoration of the lordosis and compensatory kyphosis in the thoracic spine, and you can see the clinical picture there. This is a worst case because this lady's fused from way up top all the way to the pelvis in a coronally and sagittally malaligned manner. And then the option really is a PSO. There's the dissection, removing everything, re-instrumenting, and then doing the wide decompression with 4 nerve roots displayed here with subtraction of the pedicle, and then closure of the pedicle osteotomy with the small rods and put the long rods for stability of the entire construct. And you can see we were able to get coronal correction as well as sagittal correction. And the sagittal correction is amazing. When you use the table, it really helps you correct with leverage from top and bottom. This is the clinical photograph. She also has a Sprengel's deformity as well, but she's able to stand in good alignment and balance. So what are the pitfalls? The pitfalls are blood loss, neurologic compromise, non-unions, PJK. I'm only going to talk about neurologic and non-union. The thing is that we can control the blood loss with tranexamic acid. We can control the neurologic injury by making sure it's decompressed properly. The neurologic compromise, this paper was published many years ago where there's 11% loss of neurologic in these PSOs, but the permanence only 2.8%. And most of these are from dorsal impingement and dural buckling. And these are the two things that are a problem. And dorsal impingement can be solved by actually making sure your decompression is good. One of the tips I can give you is that the working triangle is very small. This is the upper nerve root, this is the pedicle, and this is the lower nerve root. So people forget sometimes, they put the spoon and leave it there. That is not good because you're compressing these nerves as you're stretching them outside. So keep your working time fast and don't leave the spoon and forget about it. This is an example of a dural buckling. Patient who had multiple surgeries, failure, and then had a PSO, as you can see there, but then developed neurologic problems, and he had a complete block because of dural buckling, because the dura was like leather. So this is one of the things you can do is a duroplasty, and you can put a triangular graft by cutting the dura down the middle and then using this triangular graft. He recovered everything after the duroplasty period. I have been using the 4 rods for many, many years, since 20 some years now. This is an example of one where you put short rods and then long rods across the PSO to prevent fracture, period. So You can also do that with non-offset system. You just have to bury the rods close to the osteotomy deep. We looked at this in a multi-center group, and we put them into 3-rod and 4-rod categories. And we found that there was a high rate of non-union, 27% in 2 years, and there was a low rate of instrumentation failure with 4 rods, satellite constructs, larger diameter rods, avoiding some of the titanium rods, and sometimes adding intrabody fusion helped. Bottom line was that multiple rods were helpful in this case. So in conclusion, I think PSOs are very useful in revising sagittal plane deformities. You require a large decompression and dissect the nerve roots out. It's mandatory, and use temporary rods and a table that can bend, which is helpful, and then using multiple rods to reduce rod failure and non-union. Thank you very much.
Thanks, Munish. As I told you, I always learn from this lecture of yours in spite of hearing it so many times. Excellent technical details discussed. We'll take questions later on while Babu comes up with his presentation. Kshitij, can you play Babu's talk, please?
Hello, everyone. I thank SRS and ASSI for giving me this opportunity to talk about the vertebral column resection. We know that the vertebral column resection is a quite powerful tool, and it can correct very severe deformities, and that's why its indication remains the very severe rigid deformities, which can be secondary to post-tubercular, congenital, neglected trauma cases, post-traumatic cases, iatrogenic cases, and the ankylosing spondylitis cases, especially if there is a more than 10 centimeter of sagittal vertical axis shift. So posterior column vertebral resection alone from the posterior approach, it was described by Suken et al. And they named it as a very formidable operation, which is reserved only for the most tenacious spinal deformities, and that remains true to the date. It's a technically demanding surgery. The operating duration, blood loss, surgical site infection, the overall complication, the risks, they are quite high, and the neurological complication, they have been cited at around 14% in this surgery. This is an example of a 115-degree severe post-tubercular kyphosis. She was a 22-year-old female. You can see that the chest is ballooned out from the front back because of the pediatric, the onset of the nature, and this is quite rigid deformity, sharp, angular, and the D7 to L2, it was fused in a single mass. And this is the CT scan of the same patient, and this required this sort of a big correction. So you can see here that it is very difficult to close. If we try to close the spinal cord over this gap, then this can lead to the spinal cord compromise, and that's why we put a cage here in between this thing, and then we have to also put a temporary rod here when we are doing these osteotomies, and then we correct the final deformity. And this is the correction which we can achieve, and we have used a peak cage here. And this is the correction. You can see here the pre and the post-op comparison. This is again a case of post-traumatic. Sometimes in post-traumatic cases, the deformity is much. However, the disc space is mobile. But in this case, you can see that there was a fusion area in front. So we just broke this the bone column, and then we put a cage here because there was a quite large correction was required, and then on this cage we corrected this deformity, and we could achieve a very good sagittal balance in this patient. This is a case of post-tubercular kyphosis again, and you can see here the very severe negative sagittal imbalance, and then again with the help of the VCR we can get a good outcome. Now, this VCR can become very challenging, especially in pediatric age group, because the average blood loss is 2.5 to 3 liters in this surgery, and in 2.5 years boy, the average blood loss, blood volume is around 1.5 to 2 liters. So again, this becomes very challenging, and this has to be coordinated with the anesthetist, so that you can be and you have to be very quick when you are doing these sort of surgeries, especially in pediatric age group. And this ultrasonic scalpel remains quite useful. The other another challenging problem remains the availability of the specific implant, pediatric, especially the length of the screws, because the pediatric systems, they don't have, these longer screws. So again, you have to be very careful and you have to look for whatever is the best you can get. So in this, we had to use the cervical implants and the pediatric combination of the screws, and we could get the a good outcome in this patient. Now, this VCR, when you are doing at the cervicothoracic junction, then it becomes very challenging because of the unique anatomy around the cervicothoracic junction, and the arch of the aorta remains in front, and also the vagal fibers, they are there. So when you are dissecting around the vertebral column, when you're taking out the ribs, and when you're dissecting around the spinal the column, then there is a very high chances of the patient going to bradycardia, and the anesthetist again has to be taken into confidence, and they should be ready with the atropine in case there is a bradycardia. So this was a very severe with the cervicothoracic scoliosis, and you can see here that the scapula is touching the mandible, the ribs, they are touching the pelvis, and it becomes very painful. And there is a fused mass here, this thing, and this is just to show you the MRI and a syringe here, and we had to go for VCR, the cervicothoracic VCR, and again the cervical pedicular screws, they remain a must for these sort of deformities because we cannot correct them with the help of the lateral mass. And this is how we corrected it. You can see here that the scapula and the ribs, they have moved away, and this is there was such a powerful correction that the incision line actually moved into the opposite direction. You can see, and this is the post-operative, the lateral views, and this is the bending view to show you the correction in the rib hump in this child. Similarly, in the lumbosacral junction, if there is a deformity, especially congenital ones, then again it becomes very challenging because of the unique anatomy, and one has to be very thorough with the anatomy around that particular area because here the aorta and the iliac veins, they are bifurcating. In this area, there are strong ligaments which are attached here, and in this case there was also, you can see here, this was a mass here, and again there was no way that we could have corrected it without VCR in this patient, and we had to resort to the VCR. And the other problem was because of the distal fixation, there was no point in distal fixation, so we had to use 2 S2AI screws in this patient, and this is the intraoperative picture after the deformity correction. And there was a sacroiliac dislocation as well. You can see here in the preoperative X-rays. So we had to use this thing, and we could get a good decent correction and the restoration of the lumbar lordosis by doing a VCR here. Now, another use of VCR is in very severe Angst-Pond deformities, which we just talked about. And these cases, they require meticulous surgical planning with incorporating the C7 translational angle, the femoral obliquity angle, and the pelvic tilt correction angle. And these cases, sometimes the 3D printed models, they help us very well. And in osteoporotic bones, we have to use the cement augmented screws as well. So this was a case in this, we planned the VCR and the PSO in this patient. You can see here the preoperative and the postoperative X-rays with the decent correction in this. And this is, this is just to show you that how much correction you can get intraoperatively with this thing. This was again a very severe case. And again, in this case, we had to do for VCR and the PSO and the SPOs. In this case, we required 140 degrees of correction, so we have to resort to 2-level VCR. We did it in the single stage. Again, this has to be coordinated with the anesthetist, and we proceed to the another VCR only when the anesthetist and the patient's general hemodynamic conditions permit us. And again, you have to be very fast, and this how we could get the good correction in this patient, pre and the postoperative clinical pictures. So now the vertebral column resection originally was described by Boachi, and they did the anterior followed by the posterior approach. So this was the tradition, and with the Suk article, we are able to now do it with the posterior approach alone. However, the complications, they are also less with the posterior alone VCR. However, there are some cases in which you require to do anterior plus posterior VCR. This is a case of 18-year-old male with progressive deformity, and this is a very dysplastic sort of the deformity in the lumbar region. And when we looked at the CT scan, you can see that the whole of the vertebra is actually extruded into this thing, and you can see here that there is a severe the dural ectasia as well. and this is the CT scan of the patient. So there was no way that doing only from the posterior approach could have put the nerve roots into danger, and being the lumbar spine, it was very crucial to save the nerves. So again, and this was a case of neurofibromatosis. So again, we had to plan it for the front and the back, and we first went with the front approach. We had to ligate the iliolumbar vein, and then we took out the L4 vertebra from the front, and then we came back posteriorly. We completed the VCR from the back approach, from the posterior approach, and then we corrected it, and we had to use the kickstand screw to shift to to get the coronal balance in this patient. And this is the postoperative the clinical pictures. Another important area of front and back VCR remains in the cervical spine and the post-tubercular deformities, very stiff deformities with presence of the vertebral artery. The posterior VCR alone is not feasible, and that's how we this is the preoperative pictures. You can see there is a heel scar. And this patient, first we did the burr. We used a high-speed burr, and we burred everything, whatever was there in the front. And then we moved laterally till we get the bleeding from the vena comitatus, and then just left the bone there. Then we put a small mesh cage here. You can see that there are 2 rows of holes here, and then we strip the patient, and then again we burr everything from the posterior side until we get the bleeding from the vena comitatus around the vertebral arteries. And then with the help of these particular screws, and we crack open the foramen transversaria bone, and we correct the deformity. And then again we have to go in the front, because the cage which we put initially get loosened, and then we put a bigger cage, and we put a plate here, so we could get a correction from 97 degrees to 50 degrees. And we use the particular screws on one side. The other side, the landmarks were not clear. We put it freehand, so we had to use the lateral mask on the other side. And this is the correction. This is the post-operative. She had C5 palsy initially, but she recovered within 3 months, and this is after the 6 months follow-up. Another case similarly, and we used in this case we could put all the particular screws freehand, and we have used the C2 laminar screws. Again, this is a very useful thing, and this is the CT scan. You can see here the perfect placement of the pedicular screws, cervical pedicular screws. And these strategies were published, and these cervical pedicular screws, they're very important if you're going for a VCR or a major deformity correction in the spine. Now, coming to these sort of cases, the traditional VCR becomes challenging, and the neurological complications, they are very high, because the spinal cord is actually stressed over the Skyphus and over this gibbus, internal gibbus. And when you have taken out the posterior elements, then this actually falls, the spinal cord falls on this internal gibbus, and when you take out the posterior vertebral wall, then leads to the neurological deficit in many of these cases. So for these sort of cases, we have published this modified posterior vertebral column resection technique. In this, and we have compared it with the traditional VCR, and we have shown that this technique is quite safe even with the traditional VCR. But in these severe deformities, we are using this technique now for the last 4 years now, and we have not found a single the neurological deficit in these cases. So the posterior elements, they are retained till all these steps of PVCR are performed. So what happens? The spinal cord remains hanging on with the with the posterior elements by the epidural veins, and there is the spinal cord is not actually draped over the internal gibbus, and so there is still some space between the posterior vertebral wall, and we can easily complete the VCR, and the posterior elements, they are taken out at the end. So this is like you can see here that we have completed the VCR, but the posterior columns, the posterior column is intact till the end. And this is to show you just how healthy you can see here, that the spinal cord is still pulsating, which I'm sure that it's not possible if we have just done the vertebral column resection with a very severe deformity. So this is the post-operative, the clinical pictures, and these sort of severe deformities, again, they require this modified vertebral column resection, and we could get good results without any neurological deficit in many of these cases. Again, another case, very severe deformity, and this modified posterior vertebral column resection is quite useful, and without, it's very safe from the neurological point of view. This is the pre and the post-op pictures, comparative, this immediate post-op, and the 6 months of the surgery. The another useful tool is to use these 3D models intraoperatively, which helps you in putting not only the screw placement, but they also helps you in planning your osteotomy, the asymmetric VCR you can perform with the help of these osteotomies, so that you can get the maximum correction in these cases. The another The another, the problem is when there is a severe kyphosis, then if you do after the deformity correction, the spinal cord level is higher as compared to the rest of the spine. And when the patient gets supine into the immediate postoperative period, then the spinal cord gets kinked because of the soft tissues. So you need some sort of protection, and sometimes it is not possible to put the transverse connector in that area also. So we have published this technique of using the mesh cage. We just cut it open and we secure it with the help of the tension band wires, and we could protect the spinal cord. Another useful technique is which is very useful in these cases is dynamic spinal cord mapping. And you can just with the help of your neurophysiologist, you can see at what level actually is the problem. So what happens when you are doing these severe corrections, sometimes then most of the time the surgeon ended up labeling the site of VCR as the culprit. But actually, when you're doing these sort of these corrections, the screws, they can also move and they can also get problems. So this dynamic spinal cord mapping actually can tell you the exact point of the neurological compromise. And we have also using this transspinal marginic, which has been they started from our institute as well. Only we use these pedicle screws, we stimulate them, and then there's a circuit formation around the spinal cord, and again we can pick the exact space where is the neurological compromise exactly. So the vertebral column resection is a very useful tool if applied properly, and I would recommend everyone to read these three the landmark papers, the vertebral column resection from the front and the back approach by the posterior vertebral column resection, as well as the modified VCR. So the take-home message is that the VCR is a very powerful tool, and it should be done with the neuromonitoring. There is high potential for neurological deficit. The mean blood pressure during the VCR should always be kept above 80 millimeter of mercury. The blood loss has to be minimized. You should be very quick. Time is blood in spine surgery. Then the use of ultrasonic scalpel, hemostatic agents, tranexamic acid, it should be used. They should be used judiciously, and one should avoid hypotension at any cost. And it's a teamwork, and your team should be well equipped and well trained when you are doing these sort of procedures. Thank you.
That was wonderful, Pavak.
Can I invite Dr. Rajasekaran to please, if you want to share live, share your screen? Yes, please. Thank you. Go on.
Okay. Thank you, Basu. Thank you, Munish, for this opportunity. That was a great talk by Bhavuk. I think he has actually mentioned everything that I need to tell. So we have been doing this closing opening wedge osteotomy in TB kyphosis for a long time. And initially, we know that all these cases were treated by an anterior surgery for a release, and then they were done by a posterior stabilization. But when we looked at this classification, which we published in 2018, and we now know that almost all these cases are done only posteriorly. The current thought process is that the front door to the spine is actually through the back. When we look at all the osteotomies and the surgical procedures that we have done, in type 3, where in TB spine, most of the time the posterior column is also functionally lost due to the dislocation of the facet joints, we found that there is a difference in what you need to do when the deformity is less than 60 or when you have much more severe deformities. That's because when the deformity is less, when you have to correct, a simple osteotomy, a wedge resection, and a posterior closing procedure is quite sufficient. But when there is a very more severe deformity like this, when there is a sort of buckling collapse, when you take out a wedge, which may represent multiple vertebral bodies, and then you just only do a posterior closure, then that is very detrimental for the spinal cord because there is a kinking of the spinal cord, or sometimes you can see that the cord herniates through the laminectomy defect. And so what you need to do is not just a posterior closing. This has been actually shown very well in animal model studies by Dr. Kawahara, where if there is an acute shortening of more than 15 to 20 millimeters, then you get a kinking of the anterior spinal artery and you get a neurological deficit. So you not only course posteriorly, but you also need to sufficiently lengthen anteriorly so that the cord is well preserved. And that's what we call it as a posterior closing and anterior opening or osteotomy. So this is what we need to do. We published this nearly in 2008, our initial cases of 17 patients, where we showed that this was very much important for the cord. And subsequently, in a very good paper by Dr. Sudhir, he has also shown that when you lengthen the anterior column first, before you close posteriorly, then that is really useful to get your sagittal alignment also very well. So adequate and judicial increase of the anterior column is very important. Now, my topic was the surgical steps. So the most important thing is positioning. Many of these patients, you find that the thoracic spine has already gone into a compensated lordosis, and sometimes at the cervicothoracic junction, there is so much of lordosis over there. The inlet to the thoracic inlet is very much compromised. You need to be really careful in positioning. Neuromonitoring is an absolute important thing. And we always keep the hypotensive part of the anesthesia only during the exposure. But actually, when we start the osteotomy, we make sure that the map comes up sufficient. The approach is midline, and it's a little wide so that you get a bilateral transversectomy approach. You need to excise the rib heads of the apex. 2 or 3 apical rib heads have to be removed. And once you remove the transverse process also, then your dissection can be done on the outside of the body, and the entire apical wedge can be easily identified. When you're applying the pedicle screws, it's also important to note that you need to be careful, because very often the vertebral bodies above the apex and the vertebral body segments below the apex are in 2 different rotations and 2 different angles, and so you need to be careful on how you orient your pedicle screws. In gross cases of buckling collapse, if you have a navigation, then it's very much useful. We have found not only in applying the pedicle screws, but also carefully planning your wedge. It's very useful. You then apply the temporary rod, and then you start doing the laminectomy. And we have found, it's my personal preference to do a laminectomy and to keep the whole cord in front of your eyes before I start doing the wedge or the osteotomy. I find this very useful. When you do the laminectomy in a TB spine, you have to keep your laminectomy much more than what you normally do for other types of osteotomy. This case illustrates the reason very well, because you can see that this wedge of bone actually represents 3 whole vertebral bodies. And T10 is actually coming in close contact with L2. So when you remove this wedge, that represents 3 vertebral bodies anteriorly. And so you need to do a very good laminectomy over here to cover your closure. Otherwise, you will find most often the lamina above comes and dips into the canal and causes a spinal cord compression. So you need to do an adequate laminectomy is very important. At the thoracic level, you should not hesitate to actually sacrifice 2 intercostal nerves, and that when you do it and you lift it creates a very good plane between the dura and the bone that you need to resect. Your vision becomes fantastic, and then you can go on to do your wedge osteotomy. It's important to know that when you're removing the wedge, you can do it with an osteotome carefully, or a burr, which is more often used, or now we use the ultrasonic cutter, which is still better. It really saves a lot of blood. You start below and you don't start from the top. That's for the beginners. You need to leave a thin shell of bone over here, because it forms a natural retractor and protector for the spinal cord, and it also saves a lot of epidural bleeding over there. So you keep it till the very end. You complete it, and in some of these cases, I don't create a complete wedge over here. It's just like you do a corticolysis. You just leave the anterior longitudinal ligament a little bit intact so that it doesn't translate. So in many of these real severe cases, you find that there is almost an anaconda type of feeling over here. And then comes the most important part. When you have completely done the osteotomy and removed the wedge from both sides, you then get on to make sure that the temporary rod is holding well. And then you go on to the removal of the posterior thin wafer vertebral wall. This is very important part. And in our experience, I have found that this is one of the times when you can get a neurological deficit. Many times, even when you don't get a neurological deficit in TB spine, because some adhesions are there. If you are not careful to have released the adhesions and then you tap on the posterior vertebral wall, there is a sudden fall in your signals. It picks up a little later, but it just puts a lot of tension on you. You need to be very careful at this spot, and this is very, very crucial. Now, once that wedge has been done, you find that the spinal cord is always pulsating over here. You can see that we have sacrificed two intercostal nerves. Then you choose an appropriate sized cage. Now, I always close the wedge after placing the cage inside, and not close and then place a cage, because that can lead to a little bit of vertebral body translation, a translation more in the sagittal plane, and that can be a cause for a challenge for the spinal cord. So if you have, you choose your appropriate cage and you place it anteriorly, and then use it as a fulcrum, and then you start getting the correction. The correction is got both by appropriate contouring of the rod and in situ rod bending, and by also compression. By a series of these three maneuvers, you can get a very good correction on a cord. You have to be careful that the lamina here are not compressing on the spinal cord, and then you make sure that the spinal cord is still covered. Then once you do that, you can, like Bauk said, you have to protect the cord. That's very important. In very severe kyphosis, after you have done a good correction, you will find that the cord is actually bulging a little bit outside. And if the patient lies supine in the postoperative first 1 or 2 days, that can be a cause for a challenge for the spinal cord. So you either protect it by 2 transverse connectors if there is space, or you will have to use a mesh and then protect the cord at the end of your procedure, and that's very important. So this is a patient, what you can see over here, and from 106 degrees, it has been corrected well. And another patient over here, you can see that there is a good correction. And in our 106 patients for severe kyphotic deformities, less than 90 degrees, you can find that your corrections can be very high. And more than 90 degrees, especially when it goes to 110 or 120 degrees, approximately 50% correction is what you get without a problem. Neurological deficit, in simple cases, there is no neurological deficit. In cases where then greater than 90 degrees, especially when it goes to 110 or 120, you get sometimes intraoperative changes without clinical deficit. And that's exactly mostly in the time when you are removing the posterior vertebral wall, but then they recover very well. We had 4 patients with partial deficit who fully recovered very quickly, and we had 1 patient with a full deficit who partially recovered. And so what's most important is that we need to be very careful about proper positioning. Neuromonitoring is very important. A wider laminectomy is required than when you do an osteotomy for other etiologies. Remove the wedge, maintaining a very thin layer of posterior cortex till the very end. Choose an appropriate size cage. And if you need to have a more accurate or a larger anterior wall, anterior column reconstruction, you can use a expandable cage and correct the kyphosis by gradual correction with good monitoring of the signals. Thank you very much for your opportunity.
Thank you very much. Great talk. Fantastic talk. Now, I think, is there any questions from the audience or the panel?
I think we have time for a couple of short questions, if anybody has.
So, can I ask Bauk? Bauk, great cases and excellent illustration. So, in your modified approach for COVO, the rationalization for holding on to the posterior structures till the very end. Do you find that it interferes with your vision and doing the osteotomy?
No,
Because I
sir.
find it quite useful to have the whole cord in front of me so that I know where I'm working.
It is a little bit technically challenging, sir, but actually you take out the lateral half of the lamina. So actually just a very small part of the dura is not visible. The rest of the cord is actually quite visible.
So once you have put a temporary rod, so what is the greater advantage of having the posterior column intact?
So the cord is actually hanging from the posterior elements from the epidural veins. And when you do this sort of osteotomy, you will realize yourself that, the cord is actually much healthier and the cord is actually not falling over the posterior vertebral wall. So when you take out the posterior vertebral wall, you still, if the cord is draped over the posterior vertebral wall and you are inserting the horseshoe or discectomy forceps to take out the posterior vertebral wall, still there is some space because the cord is actually hanging up from the posterior elements.
So what's Munish's take on this? Do you keep the posterior part intact until the very end, or you take them off early?
So, I've been using this technique for a long time. And I learned it from a guy named Rajasekaran from Norway. And basically what you do is you cut in the medial part of the lamina, and you take the pedicles. I don't know if you remember, but basically you have the whole lamina, and there's these attachments of the dura that keep the cord up, and it prevents it from falling, because when you're taking that posterior wall, the dura has something just holding it gently up the cord, and so it's not falling, because that's when you're fighting against the cord every time as you put some instrument between the cord and the posterior wall to push it down. And so I've been using it for a long time now, and I find it very helpful, but it's also very useful in like a bad coronal VCR. So what you do is you take the concave side first, because the convex attachments of those to the dura keep the cord on that side and prevent it from falling into the concave hole that you create. So it's not just a sharp angular kyphosis, it's also in a bad coronal deformity. So I use the same principle in both directions. And then the cage, I started using that many years ago because I had a case where the cord was higher than the instrumentation. So I cut the Harms cage and put it on there a long time ago. And I think it's very useful. But I also use sometimes ribs or a femur that's cut in half. So I think both those techniques are very helpful.
Thanks. That was really good. Any other questions for any other faculty?
So I have a case which is very similar to the Dr. Rajasekaran's talk. So just to save time, maybe I can show the case and
yes, I think that would be great. You can go ahead with your case, Kshitij.
So all these points are there in this. So this kid, can you see my screen?
Yes.
Just a minute. Play it again. So this child had TB at the age of 13, and unfortunately, this is a kind of a sad story that the doctor who was treating him documented this progression of the deformity so very well, almost like a textbook picture of buckling collapse that is described by Dr. Rajasekaran. So by the time he presented to us, he was 21-year-old male who had this sort of a deformity. And you can see that scar that is of the sinus discharge he had as a child, but it was completely healed, but it was tethered to the underlying bone. He had absolutely no symptoms, no neurological symptoms. The only thing he complained of was some tingling sensation in his legs when he used to sit for a long time. But his major concern was cosmesis. The neurology was absolutely normal. No brisk reflexes, no upper motor neuron signs. This was his X-ray. I'll show a close-up of the MRI. And the MRI shows the spinal cord, kind of a type 3 cord at the apex. And this is the apical close-up of the CT scan. And 4 vertebral bodies are kind of amalgamated together, T9, T10, T11, and T12. And that's how it looks. And this is the 3D CT. But I guess I'll stop here and show you these images, and then we can discuss this one.
I think you should show us the case because
Okay.
Bhavik and Raja have shown similar cases. Yeah.
I'll just run through what we did and reach the end. So we do get 3D printed models made for all these severe deformities. Just helps us understand the anatomy in 3 dimension when you are dissecting intra-op. So we had planned a dissection of that shaded area, as you can see, and we had 4 ribs to remove on either side. This is his positioning, is exactly described by Dr. Munish, where you're going to wedge the patient on the table, and the table has a kind of angle there, which we will close as the deformity closes, just to get some help. These were his baseline neuromonitorings. MEPs were there. This is his exposure. Left side is the caudal end. You can see we normally use reduction screws everywhere, but just to save cost in this patient, I have used reduction screws in the lower end and not at the top. But I could have made my life more easier by putting reduction screws everywhere. Then the usual kind of costotransversectomy approach, and about that kind of talk about whether we leave posterior elements behind or not. Actually, my professor, Dr. Lahiri, has been doing this. I mean, I don't know any other way of doing this deformity, because he has always told us not to remove the posterior elements, and he calls it like the surgeon's irresistible desire to see the spinal cord that you should avoid, especially in this deformity, for the several reasons that Dr. Munish just mentioned. So here you can see all the posterior elements are intact, and you can see that Y disc, and it very much corresponds to how the 3D model looks like. The L1 I have marked there, T8 is marked there. And when you do a costotransversectomy approach from the side, the key structure that we like to advance, and the way Dr. Lahiri likes to do it, is to see the foramen very well. And you can see the pedicle of 9, 10, 11, 12 from the outer aspect. And then because you have tied the nerve roots, you know where the foramen is. And because you know the boundaries of the foramen, you know where the spinal cord is. So you don't really need to see the spinal cord to know where the spinal canal is. And that's how we do it. When we look at the side picture from both sides, and obviously this has been done both sides, there are several advantages here, because you are not going to get into epidural bleeding all the way. Your lateral exposure will be complete without getting into the spinal cord. And the whole purpose of seeing this dural sac is to see the boundaries of the dural sac, which you can very well visualize by just looking at the foramen. So this is how the kind of 360-degree around the spinal column. And that's the wedge that we had planned to resect, and we used osteotome to get most of the wedge out. And before starting this, we always use 2 temporary rods, and we use 2 temporary rods, not a single temporary rod, because these get very unstable. And we like to use these aluminum hangers, which are kind of have more malleability to them. They're very easy to bend, and we use them on both sides, and we curve them like that so that we can work around the column without the rod getting in our way. And then once most of the posterior column and the lateral pedicle wall has been thinned down, combination of burrs, curettes, and ultrasonics, or whatever you want to use. But when you get that to that extent, I'm using a very small curette to push down that posterior wall into the cavity that has been created. And here you can see on the video that I have disconnected the posterior wall from the pedicles now, and then it is slowly going to move away. I'm going to dissect it. And and Dr. Munish just said that it keeps the dural sac up. You can see how the dural sac is still up because of those posterior elements holding the dural sac in place. And that really helps remove these posterior elements, posterior wall of the vertebral body quite easily. That's how the posterior wall looks like from both sides, moved in single piece if you thin it quite good enough. And this is the view from the side. You can see how high the dural sac is traveling up after removal of all the anterior elements. And then once you get the lamina out, at this point in time, we actually lost signals. And that was kind of a mistake that I made here because I wanted to get pictures and I got distracted here. But you know, the moment I stopped manipulating this and got the blood pressure up, the signals did come back. So here you can see on the picture very clearly that after removal of the posterior elements, you can see the dural sac has fallen down into the cavity. No correction has been done here at present. Just the posterior elements were removed and the dural sac has fallen down. And then the sequence of correction as described by Dr. Rajasekaran here. So number one, distract the gap. The second is release the one side that is holding. Third is that you get an under contoured rod and push it down into the reduction screw so that some correction happens. Fourth, you compress on both the rods so that shortening happens at the column, and then just repeat this cycle. I mean, I think I did this for at least about an hour and a half, maybe 14, 15 rod exchanges, slowly, gradually changing the rods to get correction. And obviously, I was guided by the neuromonitoring all the time, checking that is the neuromonitoring fine, and then only going ahead. Every time distracting, tightening, compressing, and then going around in circles, 1, 2, 3, 4. And then replacing the titanium rods with cobalt chrome rods at the end when I had satisfactory correction. And obviously all that compression final last few steps were with a cage, but initial probably 10 or 12 were just with that lamina spreader, but the last few ones with a cage and then compressed from the back. And then there is a satellite rod, and then the en bloc lamina that was removed, I just used it as a cover for the posterior dural sac when you could use a mesh cage, but we had a good, like an en bloc piece of bone there. So I just covered that and sutured it. This is how it looks post-op. And this is how his pre and post correction is. And these are his images. He's about 2 years or 3 years post-surgery now. And maybe all the points that we were discussing were there in the photographs.
That's great. A great case. A couple tips. I know, Raja, you asked about the posterior elements. You actually cut the pedicles out as well. So you saw like his cord was pretty free on the side. Right there, exactly. So the pedicles are gone, the nervus have been tied, and then you take the posterior wall of the body. So there's only the adhesions between the lamina and then the dura left that keeps it up. And it works in coronal plane as well as sagittal plane deformities. One of the things that you saw in the picture is the distractor. So you use a combination of distractor, because if you put a cage and then you compress, the cage will be too short. So having the distractor there and then compressing and going back and forth is more effective than putting a cage and then resizing it. And then I prefer to use the expandable cage after I'm done with the correction, because then you're done and you get a very solid anterior column support. Those are just some of the tips I wanted to share.
Thanks. Any other questions for this shows? Dr. Srivastava as well.
So,
Kshitij, you can unshare your screen.
Yeah, it is just a tip rather, when we have this aluminum rod, so there we can get the advantage of correcting even the coronal plane deformity. So on that rod, that coronal plane deformity, scoliotic component can be nicely corrected, and then you put a rod of titanium. So that is a good base for even the coronal correction, and you correct at the site of VCR. So you get a nice correction, and then when you put the cage, then cage in is a nice proximal and distal base. Yeah.
Thanks. I think we're already 7 minutes late, so let's go on to the last case discussion with Dr. Rajat Mahajan.
Hi, good evening, everyone, and good morning, everyone in the States. So I will present the last case of the evening. So I don't have any relevant disclosures. So this was an 11-year-old girl who presented to me with the lumbosacral kyphotic deformity secondary to tuberculosis. She had lower back pain and bilateral radicular pain. Her neurology was normal. She was treated for pot spine 3 to 4 years back outside, and she showed me after 3 to 4 years when she was treated elsewhere. She was treated at that time by anti-tubercular drugs and rest. So this is her MRI back in 2016. This was the time when she was treated elsewhere by other physician, and at that point of time, she was given anti-tubercular treatment and bed rest. She healed very well with this, but unfortunately, when she presented to me in 2019, she had presented with this kind of a deformity. So in this MRI, if you look carefully, this is the remnant of L5. L5 is almost gone completely. The L4 is lying retropulsed into the canal, and there is a lumbosacral kyphosis with thoracic lordosis. So these were her CT scan images, which again show just a remnant of L5 body. L4 is lying retropulsed with lumbosacral kyphosis. These were her standing X-rays, which shows lumbosacral kyphosis and thoracic lordosis with cervical kyphosis. The lumbosacral kyphosis was around 50 degrees, was more than 50 degrees. And I also got her traction X-rays, which shows the lumbosacral deformity to be quite rigid. I don't have a proper clinical pictures, but this picture shows a lumbosacral kyphotic deformity and showing the thoracic lordosis.
So I think we'll just stop here and take the opinion of Mike, Vitale, and then Laura to how to proceed on this case.
Yeah,
Mike.
unusual. Thanks for sharing. Unusual deformity, although I've seen something like this before. You know, I think the first thing I would question is in the setting of a kid who's neurologically intact. They are neurologically intact right now?
Yes, at the presentation, she was neurologically intact. She had just back pain and some radicular pain bilaterally. Otherwise, she was completely normal neurologically.
You know, the question to me is dose of surgery, if you will, how aggressive to be, because to really correct this, you're going to need a massive 3-column with a fair amount of risk down here. And the deformity in itself is not that bad. I would need to convince myself that, because the patient is overall globally aligned sagittally, I would need to convince myself that by taking the lumbosacral kyphosis out, it would help to restore the thoracic kyphosis here, which in the end may be a problem for the kid. But I would think quite a bit as to how aggressive I would want to be here. If this was not progressive, I may just observe it for a while. If I felt it was progressive, if the back pain was too bad, I might consider a in situ fusion rather than a 3-column, which would be what would be necessary here because of the attendant neurological risk in the situation.
Laura?
I mean, I think that she's well balanced now globally because she's so the pelvis is so maximally compensated, like her sacral slope is almost behind the vertical. So I think that long term, I agree with Mike. Now she's probably in pretty good shape, but long term, obviously she's not going to hold up. I mean, to fix this, you are going to need to do I think a 3-column osteotomy and try to restore almost like a high-grade slip, try to restore that anatomy in the lumbosacral junction from L4 to S1 so that you can, and I don't know how high you need to extend it, but that's where you need to restore the balance. And I think that's probably going to be your best bet long-term.
Is Suken here? Right. Munish, what?
Yeah,
could you go ahead
I
with?
think so. I think about these a little differently. I mean, I do pediatrics and adults, so I want to prevent secondary problems. So I want to line this up now. I understand what Michael was trying to say, but I would actually do this from the front, remove those bodies, and then like the anterior posterior VCR, because I don't want to injure the lumbar nerve roots. It's harder doing this from the PVCR route. I'm very comfortable with the front, and then some of the big veins in the low lumbar spines are tough. I think the thoracic and thoracolumbar junction is a lot easier to deal with. When you get to the low lumbar spine, I really like to have that all dissected out and resect that, and put an expandable cage, and then shorten from the back and just lever that down, and then prevent that hyperlordotic upper lumbar spine and thoracic hypolordosis. I mean, this basically lordosis all the way up. So I like to fix that to prevent secondary problems. I may be mistaken, but that's the way I would think.
So
I think Raja, Dr. Rajasekaran, please, and then he can go on with the results.
Yeah, I agree with Munish definitely, because I think the child looks well compensated now, but you can see the way the sacrum is and the amount of hypokyphosis or even lordosis that the thoracic spine has undergone. So I would do something surely. Only thing is that I would differ is I would try to do everything from behind. Because in these patients where there is a complete collapse of L5 and there is a complete shortening over there, the anterior anatomy, especially of the vessels, is completely altered. I mean, they're all very, very close to each other. They're all buckled at that place. And in 2 cases in which we have tried, we had a vascular surgeon also with us, but getting a good plane in that area when L5 is completely gone was very difficult. So I would try to do everything from behind and keep the option of the anterior surgery only if it is necessary. And the same, I mean, resection from the posterior side, that get correction as much as possible. And then the question is, where will you fix inferiorly and superiorly? So below you need to get a purchase of pelvis, so SQLR screws I think will be an important thing. Maybe on the superior side go up to L3 or maybe L1 even if it has to.
Okay, so I will show what
I think Rajat, you can show us what you did.
So actually, these are all the options I was thinking. So whether I had to go anterior or posterior or all posterior with PVCR. So I decided to go with the PVCR because in tuberculosis I was suspecting that the vessels might be adhered, because secondary to tuberculosis there is a lot of adhesions are there in the vessels, and sometimes it is difficult to mobilize the vessels. So I decided to go with the PVCR, and I went. I removed the. I did the VCR of L4 and L5 remnant and fixed up to the pelvis. And I went 2 levels above, up to L2 I went, L2, L3, and then fixed up to the pelvis. So these are our X-rays. These are 2 years post-op. So I was able to make it to neutral. So the kid is now more than 3 years post-op. She is doing fine.
So I think it looks very good. You could see the reciprocal improvement in thoracic kyphosis and also cervical lordosis. So I think it looks very nice.
Yeah, I agree. I think this is the best shot she has, and I think you did exactly the right thing to try to maximally restore that and that alignment, and hopefully the alignment above will hold up for a long time.
Yeah, these were AP X-rays. So there was a correction of lumbosacral kyphosis, reversal of thoracic lordosis, and cervical kyphosis as well. These are actually the video, dance video. She, from her school, she has posted. This video is around 2.5 years post of now. She is singing to a Bollywood dance.
Bollywood dance, the most favorite hobby of every child in India now. Yeah.
So no, just a take-home message, the kids behave differently than adults in the tuberculosis due to the growth potential, as mentioned by Dr. Rajasekaran as well in his many papers. Growth retardation of the anterior column and unrestricted growth of the posterior column in children results in a late onset deformity. So deformity after the tuberculosis, it mostly involves the thoracic and thoracolumbar regions, but lumbar and lumbosacral regions can also be involved. Deformity in the lumbosacral region affects whole of the spine. So I believe early posterior fixation and fusion can prevent these deformities in children who are developing the spine at risk signs.
That was very impressive. I find that sometimes putting the cage from the back with all those nerve roots really close together is quite tough. How did you manage that?
So it was a challenge. Obviously, the cages are not as big as they can be put from interior. So it was a smaller cage, and you have to retract the roots, and always there is a concern for neurological deterioration because of the stretching of the nerve roots can occur. Unfortunately, this patient also had some economic concerns, but I believe if you can put a smaller expandable cage, then probably that is the best scenario for these patients. And you have to also, during these surgeries, you have to also, check on the blood loss that is continuously occurring, because these kids, they don't have much of a blood reserve as well. So I think you just need to go a bit slow, just your good hemostasis, and try to minimize the traction on the nerve roots as much as possible.
So Munish, from posteriorly you have a challenge of putting in the cage, and in the anterior also you have the same problem of these vessels are all kinked, tortuous, and then sometimes can be very stuck, and to mobilize them is a little bit of a difficulty we find in tuberculosis.
Actually, finding the nerve roots is much easier from the posterior approach, because there's a tuberculosis and anterior disease. So actually there's a lengthening of the posterior column. So actually the nerve roots, they are actually relatively more, the far as compared to the normal anatomy. So you can see them much clearer into TV spine.
I have a question for Dr. Gupta or Dr. Rajasekaran. Do you think?
Please unshare your screen.
Okay. So do you think spinal cord is, or rather cord equina is more forgiving when compared to a cord when it comes to posterior shortening? Are we really bothered about buckling in the cord equina region as we are in the cord?
Yeah, absolutely. Oh, go ahead, Raja. Sorry.
No, I think it's way more safer when you're operating at a lower level than at the cord or at the conus level, which is still worse. So this is more forgiving, but also you will have to remember that you are not lengthening the cord, the dura here at this point. You're having the nerve roots well exposed in front of you. And even when you put in an expandable cage and you expand the anterior column to your requirement, you will find that the nerve roots are very lax. That's a very important point when you come to the lower lumbar region. It's very difficult to stretch your nerves once you have completely exposed them.
That's a great point, Raja. The biggest example I can give you is Pankaj. You do PSOs in the lumbar spine, right? That's all shortening, and that's tolerated well. But you never do a PSO in the thoracic spine. You do more VCR. So you have to control the shortening and the lengthening. That's the classic example, and that's why I think the cord equina is way more tolerant.
Thanks, Munish. I think the discussion will go on. It's such a hot topic, and that shows us how much interest spinal deformity still has. So we'll take a final comment from Dr. Sudhir Srivastava, and he, being a part of the organizing committee of Assicon 2024, would leave behind his parting comments before we close. Over to you, Dr. Srivastava.
Yeah, thank you very much, Dr. Basu. Just a comment on that cage, large cage. Usually when we put a cage in the lumbosacral junction, we put the cage obliquely since both the side, roots are open, and then we negotiate and turn the cage from oblique position to vertical position. So that is the way out to do this from posterior side. Now, I am extremely happy today, and thanks to all the faculties on the behalf of BSS, I thank you all the nice and very knowledgeable faculty of SRS and of course our own ASSI members. And it was a very fruitful conference. We welcome you to attend this Assicon 2024 in Mumbai in January. And pre-conference, we have multiple, these collaborative sessions, and all different societies of the world are participating with us under the leadership of Dr. Basu. This has become, the program has been charted out very well. And we really thank you for this today's evening session. And of course, you got up early today morning. We appreciate your efforts. Thank you very much. Thanks a lot.
Thank you.
Thank you. Munish, always great to see you.
Thank you. I hope to see you guys in person soon.
Have a great day and a great meeting. Thanks.
Bye-bye. Bye-bye.
Thank you. Bye-bye.